All right, yo, everybody. Another episode of the MindBody Marathon. And today we are going to talk about low back pain. And we got a festive show for anybody watching. Those of you listening, we are recording this just before Christmas, and we got our Christmas gear on. So we got Zach Goulet on the show. He's got his Christmas hat and his Happy Trails Hans.
From Nakatomi Plaza.
Nakatomi Plaza. Die Hard, obviously. And then to my left, we have Dr. Matt with his Suck Brick Kid from Home Alone.
Suck Brick Kid.
Home Alone 2.
That was the second one, wasn't it?
Is that the best? Is that the better of the two?
No, I don't think it is.
I like the booby.
It is more entertaining.
I like the booby traps better in number 2 than the first one, but overall,
the overall story is better in the first. You're right. The booby traps are better in the second one.
They really dial it in. They really honed in.
They realize that that's what the people want. Yeah. Well, for my shirt, I have a shirt I actually ganked from my grandma back in the middle school. So this is actually a ugly. It's an actual ugly Christmas sweater from old granny.
Dude, when you straighten out your arm, the elbows are like down here. It's like not even by your elbow.
This thing has seen many a Christmas parties. All right, so yeah, back pain, right? So this is kind of a long time coming episode. Obviously, this is a lot of our expertise, and we figured it'd be a nice holiday gift for people because since 80% of the adult population has low back pain,
absolutely.
So it's a thing. Too. Actually, 80% of the adult population has been shown to have disc issues as well. But either way, it's not always a disc issue. And we'll kind of discuss about all sorts of things that can go wrong. And let's start here. We've all had our instances with back pain. Zach,
include my own personal experience.
Zach, the only time you have ever called off work ever.
Yeah.
At the clinic.
Yeah. And it was like my second week there.
Yeah.
It was right after my birthday.
Yeah.
It was the day after my birthday. I had my back went out, and I don't know how. I don't know how it did, but it was after like my 25th birthday, I think.
I thought that for sure this guy was going to be such a slacker. He's calling off in his second week.
Dude, we made a bad decision.
Yeah. So what happened with it?
I don't know. I have no idea. But I do have 2 small disc bulges, L3 to L5, that we found a couple years ago.
Yeah.
When I flared my back up. Don't know how that happened. And typically, I feel like a lot of low back issues don't even happen from like high intensity work. It always happens with like low intensity every day. And I feel like that's how I aggravate mine.
I'd say like 90% of the conversation with patients, it's like, yeah, dude, I was just like bending over and like picking up a sock, or I was trying to put on my shoes or something, and like their back was out. And it's like, and they're like, I'm getting so old. I just was putting on my shoes and my back goes out. It's like, obviously that wasn't the stimulating factor. It's like, it's kind of like, why does the dam break when the dam breaks? It's not like there needed to be a hurricane to break the dam. Sometimes the pressure just builds up to a point and boom, it goes.
Yep.
Yeah, it doesn't have to be this big thing.
Yeah.
Well, I think a lot of the time when it's something really small, like bending over to pick up, a sock or putting on shoes, you're not bracing for it because it's just an active everyday activity.
Yeah.
And so you're not actively being like, all right, I'm about to lift this, bag of, weight, trash or weight or something like that. So you don't, contract your core.
Bag of trash.
Brushing your teeth.
Yeah.
Just
or tying your shoes or putting the casserole in the oven.
Yeah.
I know, Cody.
Doesn't matter when you do it.
Cody, our therapist here, whenever he's like describing scenarios, he always goes like 3 or 4 deep with examples.
It's always the most obscure.
It's so great.
Changing a tire, breaking
open up the mustard.
Yeah. But anyways, keep going.
Oh yeah. So I think a lot of people just aren't expecting it to happen because they're not actively thinking about their back.
Yeah. I've also found out through my own experience with my back issues is a lot of the time when my back flares up is when I am like overly exhausted. So like if I go for a run and I start the run, I'm like, man, I'm just like really tired. I now know that my back will probably flare up. So I actually stop that activity because I just know I'm really tired. I need to just take rest. I need to take a break.
Yeah, that's a good read. I mean, if you sense you're vulnerable,
Yes.
just kind of moving around.
Yeah.
And what I often do is I often like kind of will like put my hands on my waist and then just like fire my obliques. And then if I feel like they're responsive, then I'm like, okay, I can definitely like lift more. I can definitely challenge myself more. But if I feel like my muscles around my core aren't reacting to like firing, like when I call upon them, then I'm like, I'm definitely vulnerable and I need to ramp up my core work. And a lot of times if you're in that vulnerable state, your core responds quick. It responds really over days. And so if you're feeling a little tweaky, you're feeling like you're on the verge of something going out, well, then just kind of go back to the basics on core work. Not aggressive moves that's going to fire the hip flexors, but stuff that's just going to activate your obliques and often prevent a full blown disc issue or row blowout.
What are on your guys's end, like what other contributing factors besides like disc could the low back be aggravated? Like,
so like if we have a differential diagnosis, what are the different things? You want to take it or I can?
Yeah, I mean, there's really only a few pain generators in the spine. Discs are obviously a big issue. They're laden with pain receptors on the outside of them, so they don't always have to even be like truly herniated or they can just be bulging and create a ton of symptoms. And as Zach, as you mentioned earlier, a lot of the symptoms are even a lot of times related to general body-wide inflammation. So you can have a disc issue that's pretty low grade, honestly, but if you're inflamed from just eating bad and just living bad, like it's going to turn into a really bad issue. And mechanically, there's really not much happening. Or you can have like so there's basically two types of categories of issues within the spine itself, like low back itself. There's a disc issue, which has a litany of diagnoses. And then there's the posterior elements of the spine, which would be like the facet joints and the muscles and the ligaments. And those can create a lot of symptoms as well. So you can get what we term facet imbrication, which is basically like saying you sprained a joint of your back, but it's not like a disc sprain. It's more the actual posterior elements of the spine where the bones meet. They can create a lot of symptoms. You can literally just get a back spasm. Almost everybody all the time will get a back spasm with every single type of back injury, though. The muscles will 100% be involved. And so a lot of times people will be like, oh yeah, I just have a tight muscle in my back. And the body's not dumb. It's not going to tighten up a muscle for no reason. So often the muscles are guarding and spasming for a reason. So you can get a muscle spasms that are just muscle spasms, which is actually pretty rare. You can get facet issues. So basically kind of sprains of the spine. And then you can get disc issues. What would you say further than that?
Other than that, I mean, you can get referral pain from visceral. If you have something underlying, from the intestinal tract. Kidneys are a big one that will reproduce back pain as well. So if you have a kidney stone, most people will be like, oh, and like they'll have a lot of sharp back pain.
Yeah.
But normally, if you can pass the stone pretty quickly, I've been bit a couple of times where somebody comes in with like super acute low back, and I'm like, oh my gosh, they're really, really bad. And then like I'll see them in 3 days, and they're like, oh, I'm perfectly fine. And I'm like, I didn't give you enough to like make a 9 out of 10, a 0 out of 10. And then they're like, yeah, I passed a kidney stone. And I'm like, I always forget about like stuff like that. So that'd be another one with, women, referral pain from like the ovaries and stuff like that as well.
Yeah. What about, well, and then there's the sciatica portion of it, which is obviously a big, broad diagnosis. And that's related to basically tension along the spine, but also what we call a phenomena of double crush, where a nerve bundle can't move great up in the low back. And then secondarily, it will get impinged down into the hip and then even go down farther into the leg. True sciatica is pretty rough to manage because you have to manage the tension of the whole nerve, not even just including the back. But a lot of times it's just, if you just did kind of back exercises, that would fix it.
Yeah. And some of it is too, like different things can push on the nerve, like up by the spine. So like you can have, as we talked about, like a disc. So think of it as like a balloon that inflates and pushes on the nerve. but then you can just have inflammation fluid. So like, as we talked about, like really poor diet, that's just going to increase your systemic, ability to produce inflammation, and if that fluid is around a nerve, it hates nerves. So it'll attack the nerve. And so if you're entrapping or irritating the nerve above, there's actually research that will show farther down the nerve, the whole nerve tract will actually cause the nerve to swell a little bit.
Yeah.
So that's the swelling of the nerve itself can then cause the impingement, because now think of like a tunnel where a train goes through. If you just put a wider train in there, it can't go through the tunnel. Now it's trapped.
Yeah.
So it could be a foot issue because the nerve is swelling down there and now it's pulling all the way up to the back.
Yeah. A lot of components. I personally have had, Matt, have you had a low back issue? You have a lot of neck and upper back.
I have a lot of neck stuff, but not as much back. If I do, it's pretty acute and it's gone in a day or two. So
yeah, I had when I was 21, I had a real bad low back issue. I was on crutches for a couple of days. I still finished out the season, and I ended up getting an MRI at that time, and it was a central protrusion at L5S1, which central discs are. So we always kind of say in the office, like, not all disc issues are created equal. So basically, if you get a disc bulge or a herniation or a slipped disc, then basically they can go laterally, which is off to one side. So it'll pick the left or right side. It can go paracentral, which is kind of like the space between straight back and to the side. And then it can go central, which means that when it goes straight back, it goes straight back into the spinal cord. But the other problem is it basically modifies all direction of movement you can do, because every movement in any plane will affect the disc then. Whereas if it just went off to the left, you can actually salvage a good 2/3 of that disc with healthy movement. But a central disc is much more difficult to manage that way. So you're kind of the expert from the McKenzie perspective with that. Kind of explain those mechanics a little bit to us.
Yeah. So with McKenzie, it's movement-based, like repetitive exercise. So if any patient, has been here where you've had some type of spinal injury, whether it be neck or, mid back or low back, we typically give you repetitions of exercise. If you have a low back, the most common thing is disc, issue with McKenzie. So you're going to lay on your stomach and you arch back, kind of like a cobra position, if you're familiar with yoga. So the process, or the thought process of it is, McKenzie would disagree with it, of explaining it this way, because they talk in terms of derangements, which is basically inefficiency of the joint itself, not to one specific type of ailment, but the disc model follows best for the spine. And so basically, think of, you have a hamburger patty. And if you squeezed one side of the front of the hamburger here, the back side is going to bulge out a little.
Every time I have a hamburger.
Yeah. And so
just squeeze it out.
So because of that, as we bend forward, with sitting or any other activity, like 90% of our day is in a flex position, meaning bent forward.
Getting the casserole out of the oven and mowing your lawn.
Bending
squeezing
over
the mustard.
Exactly.
Dishes out of the dishwasher.
So we're constantly squeezing the front of the disc and protruding it backwards. So basically, McKenzie will say to go backwards into extension will slowly push that disc back in towards the center. Yeah.
Yeah.
And so that's kind of the model of it. To differentiate between central, in McKenzie's eyes, centrals are easier because it responds best to just only sagittal plane. Whereas with some of the paracentral, so think of central, paracentral, complete lateral. So, when you start to deviate from that, then it adds excessive movement where you might have to shift the body and then go into extension. I've had a couple of cases where it responds to rotation, which makes no sense to me, but it happens. So the biggest key, especially with central, as you said, all other movements can affect all of it. You have to go slow with those.
Yeah.
So a lot of the really bad central discs, you can't just go all the way up. You have to start on elbows. I've had a couple patients where just lay on a pillow and not even onto elbows. The paracentral ones are usually pretty quick because it's usually one-sided.
Yeah.
Central ones can be both sides. So you typically have a pain pattern that goes down into the buttock or down the leg. And central ones, if they're broad enough, they'll hit both nerves as they exit. So think of a tree trunk and then the roots that come out of it. So if it's central, it'll hit the whole tree trunk and all roots are affected. Whereas if it's more out to the side, it may only affect the roots on that side. So from my eyes, paracentral is easier because it's typically one-sided, and you really know you have a really bad disc issue if you have, let's say, left side leg symptoms, and then you start doing treatment in one way, shape, or form, and they come back and that has abolished, but now it's gone to the opposite side. If that happens, it typically means that the disc itself is pretty unstable. That means the ligaments surrounding it, the soft tissue structures of the muscles aren't supporting it. They just have a way worse outcome.
Yeah.
It's one of those, they're usually in 3 or 4 visits, if they're not getting better. I'm getting an MRI specifically so I can send them to pain management and get somebody to go in there and give it, an injection. The central discs, when they happen, they're more damaged because right behind the disc is, the ligament. And so you have to bulge not only through the outer layers of the disc, what we call the annular fibers, but you have to push through a huge ligament as well. So if you get a true central disc, you've had a pretty bad injury.
Yeah.
Or you've been having to do that for so long of a time, that ligament wears out. And usually it's the opposite case. That ligament thickens over time. So
I know, right? Part of the reason why I wanted to get into the weeds a little bit about specific types of back diagnosis is that I'll oftentimes get patients in and they'll be like, oh, the doctor, I got an MRI and the doctor said I have a disc issue, and they're like really bummed out. And then it's like, okay, join the club. That's a thing. We all pretty much got them. The other thing too is that, like I said before, not all disc issues are created equal. So they'll often just be like, oh, you just got to go to PT and just do this, get these pain meds and, muscle relaxers and anti-inflammatories. And then that's just kind of the general thing. And then they'll go to somebody and then they don't really specify the exact disc issue. And it's like, that's the value of the MRI, is really kind of fine tuning exactly what direction it's heading and then what exercises you can do to rectify that. So it's really important to just like not get all bummed out if you have a diagnosis of this, or if you know somebody that has a diagnosis of this, but to get really specific about what is actually going on and be very specific about those exercises.
Yeah, I mean, for anybody who's been a patient that I've openly talked to, I have 4 disc herniations in my neck. All 3 of them are above 3 millimeters, and in the neck, there's less space in the neck than there is the low back. For the most part, I mean, from general like soreness from, every once in a while, I can function pretty well. I have a physical job. I run. I
You're a living, walking herniation.
I am, like, just
and
one
you're here to tell your story.
and so that's the first thing, is people freak out, and as soon as you freak out, you've already just like kind of predetermined your outcome with it. But
and like to that point, like, people hear like disc herniation and they think it's the end of the world. But I know I've heard you say this time and time again, where it's like, at the end of the day, whichever route you go, you still need treatment. You still need strength. Like, you need rehab. Like, you need the ability to build up those muscles around, the core and the low back, the posterior chain to help to support that. So at the end of the day, no matter what you do, you need good treatment.
Yeah. I mean, the basic premise is that the body has the natural intuition to heal itself. And if you take the mechanistic approach of like, a car, if a car gets a dent in its bumper, then you have to physically do something to fix it. If there's a leak in the engine, then you have to fix it. Well, the thing about our bodies is that you don't always have to fix it with invasive treatments. You just have to nudge the body in the right direction and then give it the right resources, and then it'll heal itself. And that's a really important model. And that's not the traditional medical model. The traditional medical model is allopathic, that you need something from the outside to heal you. You need an injection, you need a surgery, you need a medication. And we have the vitalistic model, which is the approach that we believe the body heals itself. So we got to nudge it in the right direction. We just got to be very specific about the right stimulus at the right time. And then ultimately it will heal itself. I mean, there's countless examples of this, and each and every one of us have figured this out. Like, we've cut our skin, we put on a Band-Aid, and it heals up. Like, it's literally how it works in the back. There's a cut on the fiber of the disc. It hurts really bad. We get it, but it will heal, and you just have to nudge it in the right direction. but it's very important that you go to somebody who understands that there is a thing called directional preference. Like, how do you apply the right stimulus at the right time to fix that? So again, that's kind of what we're hoping to draw upon a little bit today's conversation, is like, just to give you some working knowledge that if you do get snake bit by back pain, or if you know somebody that has a scenario, you can, give them some good palliative care.
Yeah. And I think like, with that too, is how quickly you start the treatment. Like if I have if I have like a huge amount of back pain all of a sudden, like if I can get down and do, 30, 40 press ups, like, super quick, like within 10 minutes, I'm usually good. And, after that, whereas like, if you just sit there and let it kind of like manifest for a couple of days, the longer it waits, the worse it's just going to get. But it's really interesting, to your point, a lot of research shows that if you just left a disc alone and you could just grit through the pain for like 2 to 3 years, it'll absolve on its own. So like there's, very rarely will you have to have
years.
Surgery. Yeah. So I'm just saying, like if you did nothing, you
just grit through the pain for 2, 3
well,
years.
no, like I was saying, if you didn't
get a bite stick for 2 years,
if you didn't take any medicine, if you didn't, do any exercises, and you just were, hard worker, and you just couldn't stop, in 2 to 3 years, your body will actually kind of like reabsorb the herniation. So the point of that is like, you don't necessarily need surgery. I mean, if you ask a really good spine surgeon who is actually super conservative, they will say the only thing is if you have loss of motor skill, meaning that it's pinching on a nerve so bad that the muscle itself is deactivating and you can't walk. You get like where you're walking and you can't pick your foot up and it slaps the ground.
Drop foot.
Yep. Or you can't go up onto your toes.
Bowel bladder issues.
Yep. Those are the stipulations. Now, beforehand, if you had any bit of tingling, we're gonna cut you open, remove the disc. If you have any numbness in your leg where you touch your leg and you can't feel it, that used to be in the 90s and early 2000s. That's immediate surgery. Now it's if you're urinating or defecating on yourself, or you can't go to the bathroom, or you're physically weakness, or obviously like if you tap your knee like in a reflex area and you don't have reflex. Those are the 3 stipulations. Anything else other than that, they don't care. I mean, I have patients that will lose muscle mass, but because they still can toe off, they won't have surgery.
And that just shows you that the outcomes were so bad for so long with back surgery because they were just pulling the trigger too quick on issues that they really didn't have any business managing with surgically. So it's important for everybody to understand that, those are the red flags: bowel bladder issues, muscle wasting, inability to like move normally, like go up on your toes, like lift your shin or lift your toes up towards your chin, like drop foot, all that sort of stuff. Those are big, bad red flags. But the vast majority of us just kind of have like tightness through the back, right? And just general, every now and again, it might build up to a point where you kind of feel some more discomfort. Let's kind of go over some like just general measures for like the 80% of the population that's managing just kind of your chronic tightness, pinching in the back. What are some go-to techniques for you guys?
I mean, for me, because I've taken multiple McKenzie stuff, so 90% of the people will do press ups. So laying on your stomach, as we said, arching back.
But do not arch back with your muscles, right?
Huh? No, you're using only your arms.
Be very clear about that.
Yeah. So basically, the whole point of it is laying on your stomach evenly distributes gravity pressing down on you, so it decompresses the spine. And as you use your arms to push up, it actually allows a distraction of the back, a decompressive moment, because basically your legs are pulling your spine apart a little bit. But if you're using your back, your buttock muscles to like actually push you up, you're just actually compressing the spine. The caveat of that is that once you're above about the age of 65, McKenzie will say that elderly, because their discs start to dehydrate more, they actually respond better to compressional loads with the disc. So actually standing extension and actually using your back to arch back a little bit is actually more beneficial. They changed that stance like a year ago. So
just find that rail and just bend over backwards.
I'd love to see that focus group.
Everybody leaning against the rail, the closest rail. Yeah. Okay.
So that would be one. I mean, hip flexor stretching.
Yeah. So sitting is a huge issue, right? So
Mhm.
when you sit, you tighten up your hip flexors then pull the spine into more of a lordotic or an increased curvature position. That creates that compression on what I was termed earlier, the
Mhm.
facet joints, creating those back sprains we talked about. Yeah, hip flexors, you absolutely have to keep your hip flexors loose.
Mhm.
And that's not always like stretching them either.
Yeah.
So hip flexors, especially the deeper psoas, responds really well to trigger point work,
Yeah.
like kind of compressing them with like a hip hook or like a psorite or something like that, where you just lay on it and it just releases the deep hip flexor kind of deep in your abdomen.
Yeah. So same thing, like when you don't want to do a ton of stretching, because one of the issues of why you got back pain was because you couldn't stabilize through the spine. And
Yeah.
one of the major spine stabilizers are the hip flexor. They attach to the front and to the side, so they act as guide wires.
Yeah.
So if you do too much stretching on it, you're going to loosen that, and then now it's just going to move, and you're going to re-aggravate or make it even worse.
This is hugely important
That's really
to understand. Everybody with back pain will have muscle spasms. Period. Every single case, regardless of the cause, there will be muscle spasms. So your first intuition is to stretch the tight muscle. But what we're saying is no. Your first intuition is to normalize the movement of the back, either with the press ups or whatever mechanic, based on what your therapist is showing you, what other mechanical move you need to do. And then gently get the muscles to slowly let go, but not via stretching. So don't like really try to wrench forward and touch your toes, and don't try to like crank your hip back to stretch the hip flexor. Like be very cautious to do those things.
And, and so, like, same thing, like we've treated at CrossFit competitions. And so after every patient that comes in with low back pain, like what CrossFit, person doesn't have that, you have to re-engage the core again. Because if you just loosen somebody up, they're going to get off the table. They're going to try and put a movement, now not only a movement, but now you're going to add significant amount of force behind it, lifting weights. And it's just,
Yeah,
you're going to
that's
take
not a
that
good
disc
scenario.
and bang it right to the next cavity.
So how do you manage it as a massage therapist?
Very conservatively.
I was actually telling somebody this today. They were like, I forget which patient it was, but they were like, oh, I go to my massage therapist and they often like really hurt me. And I'm like sore
Yeah.
for a couple of days after. And I was like, that's one of the things that I always appreciated about Zach is that, sometimes when you're getting worked on by Zach, it's like, you think like you're not like getting in there as deep as like a quote unquote true like sports massage or like a trigger point massage. But it's like, but then you never feel worse.
Right.
It's like
Right.
it's like when you go after a general versus like the foot soldiers, like you just want to be very targeted with your approach.
Right. Exactly. And like, I also have like, it's learned experience. And like, yeah, there's people that have gotten off my table and like, I'm sore. And I'm like, yeah, because you're just very tense. You're a very tense person. So
Or sometimes you've just been laying there for too long.
that too. Yeah. And, but when it comes to low back pain, and I kind of burned myself, not realizing that I burned myself. And I think anytime I've burned myself, we've figured out that there was something more going on. But there was a patient that I had that, she had like a little bit of like back tightness. And so typically, like if someone has a little bit of back tightness, but it's not like symptomatic, it's nothing, just like, I've been working, my back's tight, I'll hit the hips because obviously the hips are connected to the back and that can help to relieve hips or to relieve the back. Well, I was like hitting it with some trigger point and she goes, wow, that's like really tender. And I was like, yeah, it's just tight. Like, we're going to hit it. It'll calm down. And then she got flared up. So she had something going on. Then she saw Matt, but she was mad at me because I flared her up because she didn't truly request.
Yeah.
So I've learned that like, okay, if someone has maybe like a low back issue, maybe be not so involved with, because the hip is stabilizing that area to maybe minimize those symptoms, those pains, but they need to do the press ups, they need to do the hip flexor work, the trigger point work. But I've also found too, and I'm curious, anytime that I've flared my back up, my thoracic area, like
your mid back.
Yeah, more of like my mid back and everything. If I like bring my head down, it'll pull in through my thoracic. Are you kidding me? In my thoracic mid back. And then it will cause that sensation down into the low back. So I found that if I hit with a little bit of Graston, and like a little bit of cupping, but not too intense. And through the mid back, it helps to relieve.
Yeah, a couple of different things. So one, you could literally just have mechanical tension in the erectors, which they go from the sacrum all the way up to the back of the skull. But you could also have some tension on the dura mater, which is basically the outer covering of the spinal cord. And so, you know, with that being said, like it might be a smart move to, because those bulges might actually be trapping, you know, some of the dura mater of the spine, and that's preventing the full sliding of the spinal cord. So when you're looking down, your spinal cord is being pulled towards your head. And if it's being pinned at the low back, you'll feel the tension kind of throughout the spine.
Yeah. Which makes me look like a magician.
Yeah. Well, if you release the tension, then yeah.
Right.
But there are, like, you know, in ART, there's some very specific spinal cord moves you can do to kind of help that. So long story short, if that's happening to you and you kind of move your head and you notice some increased back tension or pain, tell us, we'll fix it. I mean, or tell your therapist, you should be able to fix that. The other thing too, I would say to you is that, you know, whenever people end treatment on their back, that almost always like messes with them. It's always better to, I found, do you find this too, to end treatment when somebody's on their stomach?
Yeah. I mean, for the most part.
Like laying on their stomach?
Yeah. Because when people lay on their back for an extended period of time, their back gets really, really sore.
Yeah.
Like, and I think it's just hip flexors.
It's just the hip flexors pulling. Yeah. And so I often will almost never end treatment with somebody on their back.
Yeah, same.
Because they'll just get up and be like, yeah, my low back's really sore now. And they didn't even have like a back issue to begin with. But it's like, just when you lay on a table for like 20 minutes, 30 minutes, and one on your back specifically, it will be tight.
That's why I typically, like, even when I'm treating, I'll spend a little bit more time. Like, they'll always start on their back, and I'll spend a little bit more time with them face up, because I know I'm solid to finish pretty strong when they're laying on their stomach.
Yeah.
And
it's easier to get up from a lying position because you can push up from it versus do a full sit up.
Man, that's a good point. Table. Yeah, a lot of times when you get off the table from like a full sit up laying on your back, you are firing the hip flexors.
Someone getting up like Frankenstein.
Yeah, right, dude, like Undertaker.
And they're like, oh, I need to grab my hand. I need like Undertaker.
Well, so that brings up a good point that, you know, you've noticed that a lot of hip stuff. So one of the big things with back pain can be hip generated. So the back will protect, or the body will protect the hip over the back.
Yes. Yeah, definitely.
Say that again.
So the body will protect the hip before the back.
Yeah.
So as hunters and gatherers, we ambulate, and so we're bipods, and so we have to be single-legged at one point. We all know, I mean, you know, because of all of our disc issues, people can still ambulate with back pain for the most part, unless you have a neurological, you know, symptom. But with a hip, if your hip goes out really bad, like, you cannot walk. And so as hunters and gatherers, we haven't evolved from that. So we will protect the hip, because without it, we can't get away.
That's why you get so many hip like replacements later in life, because people went like 3-4 decades crushing their hip socket with no pain. And then next thing you know, they're 65 and then they start to get hip pain and they're like, oh, it just came out of nowhere. It's like, dude, this has been dysfunctional for a minute. Like, but your hip is one of the last structures to bark at you. Your hip and your shoulder, those are like two key structures that really wait a long time to bother you. And they'll dump energy above and below them. So your neck will blow out, your elbow will blow out, your low back will blow out, or your knee will blow out before the shoulder or the hip will actually blow out. And so more times than not, like if somebody has a back issue, they have probably a hip issue. It's like very common, if not almost every single case. So
you know what else is interesting too?
Well, I was going to say, and so that's what probably happens in that case. You know, in that case where you worked on that hip, is it was protecting the back, you know, the back, because it's a stronger, you know, joint. And then you loosen it up, you took away the protective mechanism of it, and then the back, you know, or the hip blows up. So
this has been the year of learning.
Yeah,
getting interesting cases.
What about inversion?
I like it. I think if people have the space for it, I mean, it's a simple tool. I mean, I have a lot of people who have apartments, and so that's their biggest complaint.
I know. It is actually, I laugh because I have a lot of patients be like, dude, you should try inversion. And they're like, dang it, I used to have a table and I sold it years ago because I was just sitting in my bedroom.
Yeah.
He was in the laundry room or something. It's like, we'll go buy another one.
So inversion is really good as a preventative preventative measure, but it's not great for acute, because if it is a disc issue and the disc itself is damaged, doing too much inversion will pull that damaged disc, and it could actually tear it.
Again, thinking of a tear on your skin, you don't want to go wrenching your skin all around. It hurts the cut. So, you kind of just want to like basically have that sort of patched up so that there's no tension along the lines of fibers that are damaged. And if you do an inversion, then that'll pull the whole disc all the way through. And if it's not capable of holding that stress, it'll flare up.
So the big point in inversion is, again, lighter. So research will show that 25 to 40 degrees upside down is all you need. If you're heavier weighted upper body, if you're, a lifter where you have bigger muscle mass, or you're just heavier set, you want to go even lighter than that. Because again, pound for pound, you're distracting at that low back.
So you're saying horizon is 0, and so 20 to 40 degrees beyond that.
Yep. Okay. Is that. And you want to start out small, one a minute increments, come back up, and then you can build up to 4 to 5 minutes, but it's slowly over weeks, and then it's best used as preventative. But if you're doing it preventative and all of a sudden you have a really bad day, don't do it that day.
Yeah.
One, because again, if you're really acute, you could just tear the disc, have an annular tear. And that is a great way to diagnose an annular tear. Put somebody on an inversion, and if they go down and it's painful, like we have Cody bring them up immediately, and we're like, oh great, here we go.
Yeah, that's what it is. Yeah, so that's a really good point. Yeah. So, good preventative measure. Okay, what about cupping and scraping and all that sort of stuff?
I think it's good. For me, it's just if you go too aggressive, it just unstabilizes it. So if I do anything, like if they're really acute and I need to do that because I'm just not getting the back to release, I'll make sure that I give Cody have Cody give them exercises for core stabilization.
Like in the instance that you were alluding to, Zach, sometimes when you feel like like I had a case the other day. So like you were mentioning, if you move certain parts of your spine and then you notice there's increased pain, well, that's kind of a sign that like, you can put a cup or scrape that area and just get that to release on your own. Like I had a patient the other day, it was actually Maddie. And she was talking about how like, if she rotates to the right, she gets like really bad pinching on her right side. And she got a ton of treatment. She got needling, scraping, all sorts of stuff, adjustments, and it just wouldn't fix it. So like literally just like with the ART model, you just like feel and you just have her rotate to the right, and what areas do not move when you rotate to the right, and why is that pinching the disc? And then we just worked on the tight areas that are involved with the rotation, and like she walked out of the treatment with like 0 pain on rotation. And then it's like you just have to figure out like why, because like basically we're like sort of stacked, right? And then if she can't rotate her mid back on her low back, she's going to just rotate through the disc, and the disc is not designed for rotation. It hates it. So that's another important thing, is if you are super symptomatic and like really irritated, please do not like lay on the side of your bed and like try to crack your back and like rotate back. Please do not do that. You can do that if you just feel tight and you just feel a little bit of tension. That's a good move. Like just to kind of rotate, just to open things up, that's fine. But if you're really acute, please do not do that. That is malpractice on your part.
The biggest takeaway when it comes to like low back issues is that this isn't a no pain, no gain type.
Thing. That's a great way of putting it.
And I always tell people, and just through the years of doing rehab in the back with you guys and now being in my own practice, like less is more. Mm-hmm. And like even going back to inversion, like, some people will be like, I was on inversion for 20 minutes. I'm like, how did you even survive that? And also like, there's a point of like diminished return.
Yeah.
And a lot of the times like overdoing it can just exacerbate symptoms. So like stay within those pain thresholds or limits. Even like doing press ups, like, for me, Sphinx pose is better than going all the way up into Cobra pose for my back, just in general. But yeah, I think a lot of people try to push it.
And it's better to be preventative rather than reactionary. Yeah. So, inversion table, scraping, cupping, so right or hip hook, press ups. Yeah, keep these in your rotations to keep your back loose. That's great. Keep it at bay. You're going to have some back tension. That's fine. But these are going to be things that keep it at bay. When it gets really bad, well, then, pull out all the stops, like get the anti-inflammatories, like, try to really release it, see a physician, like get it properly diagnosed, all that kind of stuff. Um, but like kind of the last point I wanted to touch on, what about core work? So this is
Huge.
one of the biggest errors that I see with back pain. So kind of walk me through what you guys think about that.
I mean, it's huge. I think that it's probably the most important thing, but it depends on what type of core work you're doing.
Yeah, so kind of walk us, break that out, like flesh that out.
So like, I think most people generally think like crunches and like doing Russian twists, even though there's like a point in doing all of those is important for like looks and aesthetics. Like we need to be working on the abdominal girdle, as I would call it, and strengthening up the deeper muscles of the abdomen of like the transverse abdominis. So doing the diaphragmatic breathing, doing more like planking, doing more, oh gosh, what am I thinking of? Like posterior chain work where you're kind of moving through the hip, which you're activating the core, doing like stuff that's going to really just like cross directionally, even activate the core, like suitcase carries, things like that, like where you're activating everything and not just activating like rectus abdominis or whatever it might be by doing crunches or.
Yeah.
I would agree. If somebody's super acute, I don't like giving them a plank because I feel like if they are going to plank, they need to be like 10-second intervals or something because it's just too much abdominal pressure. And again, if you're increasing the abdominal pressure too much, because of the, what do you want to call it? The shearing force, thank you, of the spine, you could create a little bit more issue. I just find that my patients just don't tolerate it as much. I think it's a great exercise, and if you can tolerate it, that's great. But abdominal breathing's huge. Just getting the diaphragm to engage because you're using air pressure to compress around the spine and keep it in place. And
so just to back up real quick, abdominal breathing. If you're laying on your back, kind of the easiest way to do this, and then you kind of bend your knees slightly. So your kind of feet are like flat and your knees are at like 45 or so degrees. You put your hands on your abdomen, like right on your belly button. And then when you take a deep breath in, your hands should rise. And then when you breathe out, your hands should drop down.
And you should have minimal chest movement.
And your chest should move very little. And what this is doing is this is ensuring that you're using your diaphragm to do the breathing rather than what's called apical breathing, which is, or paradoxical breathing, which is basically where you would breathe from the chest. So you would go and you lift the chest up on breath in. That's bad. Basically, when you take a deep breath in, your abdomen should fill up. And then when you breathe out, it should sort of deflate. And then what Matt's alluding to is when you do this that way, there's a beautiful a motion where the pumping of the air in and out of the abdomen sort of milks and rehabs the disc. And then I think, McGill Big 3 is kind of a safe move if somebody's super acute, McGill Big 3, which is basically like slight little crunches, very light crunches, a light side bridge, not holding it for a long period of time, like Matt alluded to. And then bird dog is basically a great way, or like even like a dead bug move where you're basically trying to get cross crawl, like Zach alluded to. So left arm, right leg movements kind of create rotational force through the spine that's very safe. And then it activates a lot of the obliques and some of the deeper muscles. They're very basic movements, but super profound. Because one of the things we didn't allude to is that, and again, we could have multiple episodes on back pain, but one of the things we didn't allude to is that whenever you have chronic back pain, if you think of like your long railroad track muscles of the spine, those are your erector muscles. And those are very strong muscles and they're designed to hold you erect, like when you're standing and stuff and carrying loads. But there are deeper muscles to that called the transverse spinalis group. And they're made up of rotatories and multifidi and some other deeper muscles that, most anatomists sort of drive past. Now, those deeper muscles are actually the critical muscles for stabilization of the spine. And if you have chronic back pain, studies show that those muscles start to atrophy. And when they atrophy, that puts undue stress on the erector muscles, which is why I keep joking that any back pain, you will get muscle spasms because the erector muscles are overworking. So one of the best ways to activate those deeper spinal muscles, which you have to chronically, is by doing those very basic, simple movements, diaphragmatic breathing, light loads. Like I said, McGill Big 3. You can just Google that or YouTube it, and you can find some simple videos on it. It's really basic exercises. And then what Zach was alluding to earlier with the core work is that if your back is just tight and you're just trying to keep it safe, keep it safe and prevent a disc issue, then you don't always want to focus on exercises that are going to sort of drive the hip flexors, like Russian twist and leg lifts and just heavy ballistic movements of the legs, mountain climbers, things like that. Those are a little too aggressive. They're okay for performance, but they're not designed to be core work. That's not core work. They're great for performance, but it's not core work. It's not rehab core work. Rehab core work are like kind of side planks with rotation, dead bug, bird dog, glute bridges, these very basic exercises that sort of whittle it down to the fundamentals of how the spine is designed to move.
What I also find interesting too, and this could open it up for longer discussion, and obviously we got things to do, but I think also the importance of good foundational core work, especially when it comes to runners and like that whole population, is that it's not uncommon for a lot of runners to be osteopenic in their low back. And so, I mean, I am. And then there's
osteopenia being like low bone density.
Yes. Yeah. So I
on the verge of osteoporosis.
Yeah. And so from the physician that I was seeing when I got my bone density scan, like everything structurally down lower than the back, like in the hips and the legs, were good. But she said, yeah, you're osteopenic in your low back, which isn't uncommon for runners. Runners are typically.
Have you heard that? I haven't really heard that, honestly.
Yeah. I mean, I would think maybe just if have been a runner for a period of time and your gait is fairly well, you're just actually activating the knees, the ankles, and the hips accordingly. So your back might not be getting the stress. Because by the time that it works all the way up to the hip, it should be dissipating by that point.
Right.
It's a topic for conversation later. But like she wasn't concerned. She said it's not really uncommon, like it's not surprising.
Yeah.
And then one of the John Carroll athletes got a bone density scan and same thing came back.
Oh wow. That is weird. I've not heard that as a thing.
Yeah, I'll have to research it because I'd be surprised of how many like stress fractures I see in the low back.
Yeah.
Dude, opening up a can of worms.
Well, and sacral stress fractures. Yeah. I wonder if did she mention that you have osteopenia in the sacrum as well?
Just low back. Everything else is.
But even the sacrum
though. She didn't allude to it.
Yeah, because I bet you that sacroiliac
I think you're knowing
is vulnerable
who I'm
as well.
talking about too.
Mm-hmm. Yeah, it's really interesting. I mean, we can get to that topic on part 2 if we decide to do that. But I mean, when I was in chiro school, we were told about like 2 maybe in our lifetime of seeing sacral stress fractures, and
yeah, it's wild.
I'm on at least 2 hands, if not 3 hands now, of how many we've seen. But I think
basically what we're alluding to is that a stress fracture, like you might think of like your foot or shin, the stress fracture in the back is bad. It's a bad diagnosis. It's not a great diagnosis. It's very hard to overcome. But specifically down into the sacrum, this is a thing that we have not really seen before. And I've been in practice for 14 years. And up until the last 3 years, I've not even heard of it. I've not even like seen one case of it until the last 3 years. So it's actually kind of weird because we're seeing a ton of them now.
Mm-hmm. But I think one thing to kind of touch upon, with low back pain would be posture, because I think that just poor posture is one thing that alludes to a lot of back pain. We have a lot of huge population that just sits for a period of time. During COVID, we saw a huge uptick because people were working from home. They didn't have good office chairs. They didn't have good desk setups and everything.
Yeah.
So, that's a major contributor to it. So, basically, one of the big things that they researched over the last 5 years was, in 2017, the CDC came out with the whole sitting's the new smoking cigarettes. So everybody freaked out. So they made standing desks.
Made those standing chairs.
Yeah, those standing chairs. And then
I broke my arm.
And then we
then
we saw a huge uptick of back pain because the back is not made to be in one place at one time. So movement's key.
Yeah.
So sit to stand desks for next, and back pain went down. Health, improved from that. And the current research shows that the thing that made the biggest difference was literally just the movement of going from a seated position to a standing position.
Yeah. So if you are sitting all day, like definitely like break it up
Yep.
every hour, like get up, do squats,
Yep.
lunges, something.
Exactly. I tell patients to do every hour or every 30 minutes or hour, do 3 squats, air squats.
Yeah.
And it'll help because again, when people started going back home, during COVID and working, they were just sitting in one place for like 8 hours at a time.
Yeah.
And just, you don't realize how much beneficial it is just to walk to the printer to go get something or to go talk to your boss for a second. So
yeah,
movement is key.
Talk about the football game at the water cooler.
Yeah, exactly. The water cooler.
All right. Well, this is kind of wrapping up the episode here. I feel like we touched upon some good topics, and if you know anybody that has, chronic back pain, or you yourself has back pain, make sure you bookmark this episode. So when you get, one of the, well, let's actually real quick, let's touch on this one. Heat or ice?
All right. I like heat more for back, but the big thing is you have to be stable with it. You have to be sitting in a hard back chair or laying down doing it. And then you have to let the skin cool back down again. When you heat muscle in a stretched position, it will lengthen the muscle and the ligament, and then you'll have nothing to support it.
And then it's unstable.
Yep. So
if it's super acute, just probably ice it.
Probably ice.
Which really is only a day or two or so, right?
Yeah. I tend to find that sometimes it makes people worse because the coldness makes them contract the muscle, and then it adds compression. But like if you're really acute, ice over heat first, or if you're going to heat, you have to be in a pretty safe, and you can't do anything until it cools back down. The worst thing that you can do is stand in the shower, bend over to like put your hands on your knees and just sit there and let
stretch it. Yeah, that's terrible.
Like you will take a disc that might be slightly bulged, like a grade 1 or 2, where it's only a couple millimeters, and you're going to make it into protrusion very quickly.
You're going to knock that out of the park real quick. Cool. All right. I'm glad we touched on that topic. And yeah, if you, make sure you pull back out this episode, if you know anybody that has back pain or you yourself, and then we'll cover some other topics moving forward. So give us some feedback, see what you think, and let us know if you have any questions or concerns. All right. Till another day. Dr. Leo here. Be sure to check out my new book, Faster Without Fail, Your Guide to Overcoming Injuries and Running Faster Than Ever. It is now available on Amazon. You could read reviews on the Amazon. You can check out what other people have said about it. But basically, if you want to revolutionize your running form and better understand how to stay injury-free within the sport, this is your guide. Feel free to reach out and let us know what you think of the book. I would love to hear your feedback. But again, please check it out on Amazon. Faster Without Fail. Appreciate it. Dr. Leo here. If you want to catch me in another setting, be sure to check out my YouTube page, Running Rehab, where you will find exercises on how to stay healthy with running, how to improve your running form, and a bunch of other tips and tricks on how to get over common injuries.